Here I report on the HD17 abstract we have reported at this year's ASH. It's an update. We have published these data earlier. It's a large randomized phase 3 trial, international trial with more than 1,100 patients. And in this trial, we looked for omission of radiotherapy in PET-negative patients after our induction regimen. So usually it used to be a combined modality treatment for early unfavorable stage Hodgkin lymphoma patients, chemotherapy followed by radiotherapy. We in the German Hodgkin study group have a rather intensive chemotherapy backbone, which consists of 2 cycles of escalated BRCOP followed by 2 cycles of ABVD. So we hypothesized that this intensive chemotherapy regimen might allow to omit radiotherapy in PET-negative patients. This would be then different to ABVD-treated patients where we know that we cannot omit radiotherapy without quite significant and relevant loss of efficacy. This trial was a positive trial, so we could show non-inferiority. But we had defined PET negativity as Deauville score up to Deauville score 2, and Deauville score 3 and 4 had been defined, and 5 obviously, as positive. So the positivity included Deauville score 3. This was done when you had planned this trial for safety reasons, so we didn't want to undertreat any patients. However, now, after we have done this trial and looking at the international developments and the development of the technology itself, we thought Deauville score 3 might not be the best cutoff value. And we did analysis of all patients being treated with standard of care, so combined modality treatment within our study, and the predictive value of PET. And what we have found is that the Deauville score 3 does not mean anything in these patients. Actually, these patients, the outcome of these patients is excellent in numbers, better than for Deauville score 2, but it's very good anyway. But there's definitely no impact on the incidence of relapses, progression-free survival, or overall survival, which is not true for Deauville score 4, which makes it much easier for us, because we as physicians and also our colleagues from nuclear medicine can diagnose Deauville score 4 much easier. It's much clearer. There's less discordance in the findings. It's above liver, and that's easily to detect. It's much less patients. It used to be 1/3 of our patients which still needed combined modality treatment. Now it's down to 16% of patients. And so we can treat the vast majority of patients, more than 4 out of 5 patients, with this chemotherapy alone. It's a very quick treatment, takes a little longer than 2 months, no radiotherapy, and then patients are done. So we think this is a good recommendation for clinical use, and it certainly reflects our new standard of care. Thank you very much for your attention.